An unexplained prolonged APTT or pro time is something frequently encountered by clinicians. Sometimes the diagnosis is obvious, sometimes it's obscure. Sometimes it's an artifact of sample collection processing, and our usual approach to that is, if indicated, to repeat the test or repeat the draw and so forth. But when there's a persisting, unexplained prolonged clotting time test, an algorithmic approach is efficient rather than piecemeal approach of I'm going to order all the factors, I'm going to order lupus anticoagulant, I'm going to order factor VIII inhibitor to try to address what's going on. I don't have any disclosures. To start this, I'm going to review the plasmatic procoagulant pathways, including the tests that are associated with them, and then discuss the categories of conditions that can cause prolonged clotting times, and finally end up with discussing algorithmic approach to that. So here's the traditional clotting cascade with an intrinsic pathway. Here, down through amplification with proenzymes, enzymes, cofactors, activated cofactors, phospholipids, calcium, amplification, down through the common pathway. The extrinsic pathway through 7 also runs through the common pathway. The PTT test is sensitive to all of these factor levels, but it's most sensitive to deficiencies at the top and least sensitive to things at the bottom. The same is true for the prothrombin time, which is most sensitive to deficiencies, say, of factor 7, and least sensitive to deficiencies of things at the bottom. The endpoint of all of this, by the way, is detecting a fibrin clot and the time of occurrence of that, a rather crude methodology that we still have not advanced beyond. The DRVVT bypasses all of those. It starts off with adding activators, snake venom activators of 10A and or 5A, mostly used for lupus anticoagulant testing. The thrombin time test is simply performed by adding exogenous thrombin and having that interact with the patient's fibrinogen to convert it to fibrin, and we'll discuss how these tests are applied. So this recapitulates how we do a PTT test. We have citrated plasma. We add a contact activator like silica or ellagic acid and phospholipid, and then we pre-activate by incubating to maximally activate the contact system. Then, in a second step, it's recalcified, and the clotting time is measured, and it's sensitive, as mentioned, to all these pathways. The ProTime test is a single-step test where the reagent is added in one volume or 2 volumes, along with 1 volume of plasma. And it has tissue factor, which drives the testing through the factor 7 and then common pathway. And again, the clotting time is detected. Why are clotting times prolonged? Well, there are 4 mechanisms, basically. One is you're deficient in one or more factors. Another is you have an inhibitor. Sometimes you have both. For example, a factor VIII inhibitor causes low factor VIII and inhibition. And sometimes neither, spurious, which is a big deal for coag testing because so many things can go wrong with the patient, the sample collection, processing, and so forth. The traditional approach to a prolonged clotting time test, besides repeating the testing to verify it's real, is a mixing test which requires interpretation, and therein lies the difficulty because this testing is not well standardized. Here's a diagram of a mixing study, a 50-50 mix for 2 patients who have a pretty prolonged APTT. One of them corrects easily by adding normal plasma, even a little bit, normalizes into the reference range, where one of them has an inhibitor. This is the traditional and still accepted definition for identifying inhibition, that is, failure of a 1-to-1 mix to normalize into the reference range for the laboratory. But interpreting this is difficult, challenging, and there are no standards, good guidelines. When should you do the mixing test? How long should it be prolonged? A mixing test should provide 50% of all factors and should normalize a deficiency such as factor 8 or 9 because it brings the level up to a level that would not cause a prolonged APTT or PT. Incubated mixing studies are primarily performed to detect specific factor 8 inhibitors, and they're not recommended for lupus anticoagulant testing. However, many laboratories do offer an incubated mixing study as part of an initial evaluation. Again, guidelines are not really clear about interpreting the result, and it varies from laboratory to laboratory, although the guidelines recently released by the Clinical Laboratory Standards Institute for Lupus Anticoagulant Testing help define how to interpret mixing studies. So here's the listing of 8 conditions that can cause prolonged clotting times. We'll go through these each separately, briefly, and not necessarily in the order in which I show them here, but it's easy to remember them if you remember this mnemonic. Spurious inhibitors, congenital, vitamin K, other kinds of factor deficiencies which we'll define, anticoagulants, inhibitors, liver disease, sick, fail. Spurious coagulopathies are a big deal. They're very common, and it's the first thing one should think about when you have an unexplained result that especially doesn't fit with your expectations for the patient. Because coagulation samples are drawn into a fixed ratio of citrate to anticoagulant, a high hematocrit will cause prolongation of clotting times. The same thing happens if the venipuncturist doesn't completely fill the tube, or if your sample comes in from another place, it's a yellow fluid, but it might be EDTA, it might be heparin, it might even be serum. And then heparin from line draws, anticoagulation effects, effects of transfusion, difficult venipuncture can cause in vitro clotting, and lipemia, hemolysis, jaundice can interfere with photo-optical testing. And then if the sample, which is referred in as a frozen sample, we don't test fresh samples in the reference laboratory. They're centrifuged, frozen, preferably at below -40, and promptly. If this doesn't happen in good order, one can get artifactual conditions, proteolysis of the labile factors, activation inattentively with factor 7. If the sample is not completely frozen, if you don't spin out the platelets, you reduce the lupus anticoagulant sensitivity. Vitamin K deficiency. This is really common. It's used to cause bleeding diathesis in the newborns. When vitamin K became available, this disease has largely disappeared. It's very common in people who are hospitalized and not eating or sick. Despite being fat-soluble, vitamin K, we only store 1 milligram or 2, and we need 10% of that every day. So you're going to run out of vitamin K very quickly, or if you came in the hospital already out of it, very common. What does it do? Well, it causes gamma carboxylation, adding an extra glutamic acid residue that helps bind calcium for the clotting-dependent factors 2, 7, 9, 10, protein C and S. The diagnosis is often reasonably made just by suspicion, and then respond to the pro-time to treatment with factor vitamin K. One can measure clotting factors in a reflexive manner, not piecemeal, and observe that the K-dependent factors are low, others are normal, if you need to do such an evaluation. Anticoagulants. Our armamentarium is increasing, and these are trouble for the special coag lab for the most part. We don't want samples of anybody getting this stuff. Or if you must do it, or it happened, let us know. We'll save some money. Here's the listing of coumarins, heparins, which rack through an antithrombin-thrombin complex template method, and then the direct-acting inhibitors, which are proliferating. They're not dependent on antithrombin, but directly inhibit either thrombin or antithrombin. The typical test results you're well familiar with for coumarins, warfarin, the pro time typically more prolonged in the PTT. Mixing studies usually don't show much inhibition. If you need to, the K-dependent factors are low and others are normal. Some unusual effects include people poisoned with warfarin, or even worse with rodificum, which has a very long half-life, a couple, 3 weeks. You can bypass this with very large suprapharmacologic doses of vitamin K for many weeks. Heparin, the typical test you're well familiar with, it prolongs the PTT variably. The pro time's normal because it has a heparin neutralizer in it. The thrombin time is markedly prolonged, especially if done with bovine thrombin. And in the laboratory, we use the thrombin time primarily to identify or exclude suspicion of heparinized samples. This table shows a differential diagnosis pattern of thrombin time prolongation, the reptilase time. For example, the typical substantially prolonged result here with normal reptilase most likely is heparin. We rarely see bovine thrombin inhibitors anymore since recombinant or plasma-derived human thrombin is now used. If both are prolonged, it could be low fibrinogen, and then one can measure fibrinogen. If they're significantly prolonged, both of them, it could indicate a hereditary congenital dysfibrinogenemia, and then we can sort that out by measuring total fibrinogen either antigenically or with an endpoint method. These guys are really bad, especially these, in terms of trying to identify coagulopathy when the patient is receiving them. These have variable effects on the PTT and thrombin time, partly depending on the intensity of this anticoagulation and the sensitivity of the reagent. The monitoring, when it's needed, is done with an anti-10A heparin assay. The direct thrombin inhibitors are most sensitively detected by thrombin time testing and a specific test for direct thrombin inhibitor, which most laboratories still don't have, with variable effects on the other clotting times. The 10A inhibitors are most likely to affect the pro time, but may not do so. A chromogenic anti-10A assay, this one up here, which usually isn't calibrated to measure rivaroxaban, can be used. So it's important to know up front, if we can, is the patient getting some of these things. Liver disease. Well, advanced liver disease, as you're well aware, low platelets, prolonged clotting time test, pro time more than the others. The K-dependent factors fall off, but so does fibrinogen, 5, 11, 12, antithrombin. 8 is elevated, so that's your typical liver disease pattern, and also there's dysregulation of intravascular coagulation and fibrinolysis, dimers elevated, and so forth. Clinically, these patients more often have bleeding than thrombosis, but they can have both or risk of them. Let's see, I'm going backward. Let's go forward. Congenital factor deficiencies is in the differential diagnosis for a prolonged APTT or pro time, and this will be addressed in a little more detail by Dr. Rong He, who's speaking subsequently. This is a listing of most of the hereditary factor deficiencies. This column addresses whether the PTT or the PT are prolonged, typically, and so up here are deficiencies that affect the intrinsic pathway, including some that cause prolonged APTT but don't cause bleeding. One of these is pretty frequently encountered. These are pretty rare. Then 7 is distinguished by having a prolonged PT and normal APTT, and then the common pathway deficiencies, depending on the severity, will affect the PT and also often but not always the PTT. So that's your patterns, and then if you're testing, you're doing reflexive testing, you don't find an inhibitor or lupus anticoagulant or heparin or something, it may be appropriate to reflexively measure something looking at the frequency of or probability of deficiency based on clinical information, or if you don't have it, on prevalence of deficiencies. A little word on other factor deficiencies that are acquired. Some of these are patterns. We've already talked about a few of the patterns, and then some of them can be single factor deficiencies. Usually with a single factor deficiency, one thinks about hereditary congenital, but it can be a manifestation of an acquired disorder. Here's some patterns. We've already talked about the vitamin K pattern, liver disease pattern, the DIC pattern. You lose fibrinogen 5. 7 is pretty sensitive to that, and then you lose regulatory proteins as they're consumed by the increased generation of thrombin and the activation of the fibrinolytic pathway. Peculiarly, with inflammation, there's elevation of factor VIII and fibrinogen, but also often a mild deficiency of the factors high in the intrinsic pathway. Treatment with L-asparaginase, such as for ALL, is frequently known to cause decreased fibrinogen or antithrombin or other factors. And then there's a peculiar lymphoma with the bleeding disorder, peripheral T-cell lymphoma, that can present with bleeding, hypofibrinogenemia, and so forth, quite rare. Here are single factor deficiencies that to think about. Factor 2 can be the target of a lupus anticoagulant and can be cleared by antigen-antibody complex clearance, non-neutralizing antibodies. Also, factor 10 can be the target of a lupus anticoagulant, immunoglobulin. 10 is also low by itself usually, but sometimes with other factors, with amyloidosis because of its absorption. 5 can be mildly low in some kinds of myeloproliferative disorders, and then acquired von Willebrand syndrome, decreased VWF, and secondary loss of factor 8, which may be picked up in the PTT test. All right, now we're going to look at ICF and then one other category. Intravascular coagulation and fibrinolysis. This is a sketch of how it's thought to work. Here's the proenzyme plasminogen. There's the active enzyme, which is going to degrade fibrin into degradation products, activators from the endothelium, TPA, and so forth. In the plasma, there is an inhibitor of plasmin. Fibrin, when it's laid down, has binding sites on it for plasminogen and TPA, and so it brings these together and enhances the activation and fibrinolysis mechanism. Fibrin is sort of like platelets are for the procoagulant system. All right, so that's the sketch. This is a spectrum of conditions ranging from physiological to pathological. Physiological, you activate this system when you generate thrombin, lay down fibrin to lyse clots, and then as we become more pathological, some of the conditions are listed over here. It can be acute. It can be chronic if you've got something going on like a big aortic aneurysm or a left ventricular thrombus. Severity can be different. Compensated means the clotting factors are still essentially normal. You can have bleeding, thrombotic things occurring, or both of them, or be pre-symptomatic. Typical findings in DIC, the platelets are consumed, the protyme is more sensitive to factor depletion, fibrinogen's consumed, dimers elevated, reflecting that you made thrombin and plasmin got activated, and soluble fibrin monomer mainly is detecting increased thrombin. But these tests aren't specific for DIC, and you have to make a correlation with what's going on to diagnose DIC. They're supportive of the diagnosis but not defining, and we still don't have good probability algorithms for identifying probability of DIC. That's still mostly based on what the laboratory results are. Primary fibrinolysis means activating fibrinolysis without laying down thrombin. This is rare, but it most frequently is associated with systemic AL amyloidosis, and patients can have bleeding. It can also be seen in some other conditions. The dimer is elevated. SFMC, as classically done, would be negative, and then you can have excessive fibrinolysis and antithrombin would usually not be consumed because you're not making excess thrombin. The last category, inhibitors. They can be specific, which means an antibody against a single factor, most commonly 8, next most common 5, and so forth, or nonspecific, meaning not against a factor. Lupus anticoagulants, dysproteinemias, sometimes a monoclonal protein can interfere with clotting testing, and then global inhibitors such as heparins and the direct-acting reagents. So categories to think about. Inhibitors of specific factors, the most prevalent and important is factor 8. Factor 5 inhibitors do occur, but they're often subclinical. We don't use this reagent much anymore. And then these other factor deficiencies have been reported, but they're quite rare. Factor 8 inhibitors occur in people with severe hemophilia and mild occasionally as alloantibodies to response to a foreign protein. Acquired hemophilia is autoantibodies occurring in patients who have autoimmune disorders, women postpartum, maybe with malignancies, but mostly these are old, healthy people who start having ecchymoses and hematomas, have a prolonged PTT. The kinetics of the antibodies differ a little bit. We perform a incubated mixing test based on the factor 8 by APTT modification, and we do a 4-to-1 mix to maximize the ability of the antibody to be detected. We know what's in the test plasma, we know what's in the patient plasma. We can therefore predict what you'd expect to get with a 4-to-1 mix, around 20%. So this sample doesn't show immediate inhibition, but after an hour incubation, if you incubate the normal and the patient, you can predict what you would get, and here we don't. And so this is a progressive but incompletely neutralizing inhibitor with characteristics that would essentially define it as a factor 8 inhibitor, very likely. The titering assay or Bethesda procedure is a 1-to-1 procedure with dilutions of plasma. It's done at 2 hours. You dilute the normal plasma 1-to-1, so you get about 50%, and you're looking for that dilution of patient plasma that inhibits 50% of the activity. So this titer is around 4 Bethesda units. It's actually a titer of 1 to 3.4. Lupus anticoagulant is going to be addressed in a subsequent talk. If an inhibitor is not a specific factor inhibitor, it's not heparin or direct-acting anticoagulant or lupus anticoagulant, then the next thing to consider is it a dysproteinemia. These immunoglobulins sometimes can interfere with clotting protein assembly and function in ways that are not well defined. Rarely, they are specifically directed against a factor such as von Willebrand factor or others. So you find a prolonged inhibited PT, PTT, or both. More often, clinical experience, the patients may be asymptomatic, but they might have bleeding. So a listing of probability, an anticoagulant, lupus anticoagulant, specific inhibitor, MUGUS, and then some other conditions that cause the prolonged clotting times. So there's a quick tour of the conditions in your differential diagnosis. We address prolonged clotting times with this panel. We also, in our lupus anticoagulant panel, aren't just testing for lupus anticoagulant, which is often ordered as part of the differential diagnosis of a prolonged APTT. So we're sensitive to that, although ordering a prolonged clotting times profile is more likely to get your problem solved than that one. We have other panels, as mentioned, including some that are in-house. Many laboratories do offer a lupus anticoagulant panel. It varies in the amount of reflexive testing interpretations. This panel is less common, and then, as I mentioned, mixing studies are available in many local or hospital laboratories. This profile is available on your app. It's how we approach prolonged clotting time profile testing. We're going to do the PTT, pro-time, thrombin time, DRVVT, and also measure fibrinogen dimer. Mixing studies, if the tests are prolonged, and the reptilase time over here. And then during the course of this, the technologist, especially our clinical technical specialist or the consultant, will review this results and decide whether more testing is reflexively needed, such as factor assays or clinical information. Ultimately, an interpretation of all the results is provided. We have a couple of minutes for questions. If you have a question, please raise your hand. And we have roving microphones. All right, perfectly clear. Yes, sir. Wait for the microphone. It's about to come there.
It's on. Oh. I was interested that you're doing a fibrin monomer test. Are you doing that by You're doing the fibrin monomer test? Or DIC is interested to see that. Are you doing that by ethanolgylation, or is that another assay?
I think your question, I can't hear because of echo, is about soluble fibrin monomer test and which test we do.
Yeah, which method do you use?
This is a latex immunoassay with an antibody. It's not the same as the traditional test which actually detected soluble fibrin.
Yeah. Second, just a follow-up, do you ever do euglobulin clot lysis?
I'm sorry?
Do you ever do a euglobulin clot lysis assay?
I'm sorry, there's too much echo. I can't understand. Euglobulin lysis, no, we don't do that test. We used to, but it was abandoned some time ago because it would pick up soluble fibrin monomer or the protamine gel test. So those are no longer performed. But I'd like to introduce our next speaker. It's Dr. Rong He. Rong He is Assistant Professor of Laboratory Medicine and Pathology and a consultant in the Special Coagulation Laboratory and in Hematopathology. She is also co-director of the Molecular Hematology Laboratory. Rong.
Thank you. So how to advance the... Okay. So my topic is a screening test on working up a bleeding patient. I'll have no disclosures. So the objectives for today is first to provide a brief overview of the physiological hemostasis. Then we're going to talk about the common causes for the congenital and acquired bleeding diathesis. And then I'm going to present a value-based algorithmic approach for the laboratory testing of bleeding disorders. So hemostasis is composed of three phases: the primary, secondary, and tertiary. What's happened in the primary hemostasis as an end result is there is a platelet plug formation, which is the end result from the intricate interplay from platelet, Willebrand factor, and subendothelium. And it's an initial manifestation of a clot formation. However, this clot is still loose and unstable. The second hemostasis occurs on top of the platelet plug is the coagulation cascade with forming of a fibrin mesh that strengthens and tightens the blood clot to stop bleeding. Tertiary hemostasis is the dissolution of the fibrin clot. It is very important for the limitation of the extent and rate of clot formation to prevent intravascular occlusive thrombus. It's also very important adequate hemostasis have been accomplished to dissolve away the fibrin clot. So more details on primary hemostasis with vascular injury and high shear stress will have endothelial damage with exposure of the subendothelial proteins, importantly the collagen, fibronectin, etc. And the next step is for the platelet to come and adhere to the subendothelium, and this is mediated by von Willebrand factor, which is a multimeric protein, but it has binding domains for both the collagen and for the platelet. So you will bring the two together. The binding of the platelet to the subendothelium collagen through its receptor will result in platelet activation. Signaling transduction occurs inside the platelet, and there will be shape change, degranulation, and the release of endogenous activators. So those released endogenous activators will recruit more platelets to the injury site and activate them, and they will release more endogenous activators. So this is positive feedback loop. The end result is platelet aggregation, and this step is mediated by the fibrinogen binding to the glycoprotein 2B3A on the neighboring platelets. Secondary hemostasis is a coagulation cascade that we commonly refer to. We're all very familiar with the extrinsic pathway and intrinsic pathway. Under physiological condition, the extrinsic pathway is very important. It's a key player in the initiation phase of hemostasis. At the injury site, a small amount of tissue factor is being released, which will go through the extrinsic and common pathway and generate small amount of thrombin. The small amount of thrombin generated then serve as a spark to ignite the truncated intrinsic pathway, which comprises the amplification and the propagation phase of hemostasis, and generate more robust production of thrombin and subsequent fibrin. So as you can see that although APTT evaluates factor 12, whatever is involved in the physiological hemostasis does not include factor 12. So that's why even the APTT is prolonged in a factor 12 deficiency patient, they do not have increased risk of bleeding. So any abnormality occurs in the three phases of hemostasis can result in a bleeding diathesis. And I'm going to focus my talk on the primary and secondary hemostasis today. And they have distinct clinical pathological features. So the primary hemostasis involves platelet, von Willebrand factor, and vasculature. And the secondary hemostasis, of course, involves coagulation factors. The bleeding site is distinct. Primary hemostasis usually involves mucocutaneous sites, present with petechia, ecchymosis, menorrhagia, etc., whereas the secondary hemostasis usually involve the deep tissue, such as joint, muscle, CNS, retroperitoneum, and present with hematoma or hemarthrosis. The onset for the primary hemostasis is usually spontaneous and immediate after trauma because they cannot form the initial platelet plaque. Whereas for secondary hemostasis, the bleeding is usually delayed after trauma because they can still form the primary platelet plaque, although it's not stable. Examples for primary hemostasis, decreased number of platelets, dysfunctional platelets, von Willebrand disease, vasculature disorders. For secondary hemostasis, factor deficiencies, inhibitors. So in the workup of a bleeding patient, number one task is history of paramount importance. It will clue you into whether this patient is actually having a true bleeding diathesis or not, because sometimes the complaint is rather nonspecific. And also whether, if yes, whether this is a congenital or acquired condition, and also is this more leaning toward a primary versus a secondary hemostasis problem. And physical examination will also provide additional information on the bleeding pattern. Laboratory test will then come in and help you to confirm or exclude your working diagnosis. So during the history taking, it's very important to inquire about surgical history, but don't forget about the dental procedure. And also nature of bleeding, family history of the bleeding in the patient, but the negative family history does not really rule out a congenital bleeding disorder. Medications that the patient is taking that might increase the bleeding of the patient. We know all the well-documented anticoagulants, but also some antibiotics and herbal medications and nutritional supplements. Those can cause platelet dysfunction. And also concurrent systemic medical problems, such as severe liver disease. We know that most of the coagulation factors are made in the hepatocytes. Malabsorption syndrome interfere with vitamin K absorption. Renal failure usually can lead to dysfunctional platelets. So screening test for primary hemostasis. So in a coagulation lab that we usually evaluate the platelet and von Willebrand factor, both qualitatively and quantitatively. So for platelets, platelet count and functional assays of PFA 100 and aggregation assay. So one word of caution is that the platelet functional analysis, the PFA 100 and aggregation assay is a live functional test, so it requires live platelets. And so the assay has to be finished within 4 hours of sample collection, so it's usually performed locally. Von Willebrand factor analysis would include the antigen level, activity, and effect aid activity, because von Willebrand factor also serves as chaperone for effect aid in the circulation to prevent it from proteolysis. So this diagram shows the important surface receptor and glycoproteins platelets. Glycoprotein 2B3A is the important fibrinogen receptor on platelet surface. Lack of it will lead to Glanzmann's. And glycoprotein 1A, 2A, and 6 are important collagen receptors. Complex glycoprotein 1B95 is the von Willebrand factor. Lack of it result in Bernard-Soulier syndrome. And there are also multiple G protein coupled receptors, such as ADP receptor and TXA2 receptor, and absence of them will also lead to absent response to the agonist and bleeding diathesis. So a little bit more on PFA 100. This is a new automated whole blood primary hemostasis analysis, and in many places it has replaced bleeding test. Because it's more technically easier to perform and better for standardization. So the machine contains 2 cartridges. One is coated with collagen epinephrine, one is coated with collagen ADP. And in the center of the cartridge, there's an aperture, and whole blood is drawn through this aperture with high velocity. So this mimics a high shear stress-induced primary hemostasis. Then the aperture closure time is being measured. So when you see prolongation of the closure time in both cartridges, the possibility include a moderate to severe von Willebrand disease, intrinsic platelet dysfunction, moderate to severe thrombocytopenia, decreased hematocrit, and some drug effects such as 2B3A blocker in the patient. However, if the patient is on aspirin or NSAID, usually you only see prolongation in the epi cartridge because the ADP is a stronger agonist. This table shows you the sensitivity of PFA 100. It's pretty sensitive for detection of Glanzmann's and Bernard-Soulier. However, its sensitivity for storage disorder is not as good. And also, its sensitivity for the mild von Willebrand disease is also not 100%. The other functional testing for platelets is aggregation assay that measures the ability of the agonist to induce in vitro platelet activation and aggregation. This is low shear stress, this one. And there are 2 platforms that this assay can be performed. It could be performed in a whole blood with impedance technique or with a platelet-rich plasma, and usually the turbidity of the sample is being measured. This table summarizes the expected findings with various platelet disorders, and due to time constraint, I'm not going into details, just going over 2 examples, the Bernard-Soulier or von Willebrand disorder. You can see the response to risocetin is markedly decreased. That's because risocetin is actually an antibiotic that will open up the von Willebrand factor and exposes the platelet binding site for it. So when the patient is having Bernard-Soulier or von Willebrand disease, this interaction is markedly impaired. However, its surface receptor for the other agonists are still intact, so the response to all the other agonists are normal. For Glanzmann's, the abnormality exists in the final step of platelet aggregation. with lack of the fibrinogen receptor. So the resuscitant response is normal. However, its response to all the other agonists is absent. So switching gears to von Willebrand factor, this is a multimeric protein I measured and I just mentioned, and it contains multiple functional domains in its monomer. Has Fact8 binding domain, platelet glycoprotein 1B binding site, collagen binding site, and also platelet glycoprotein 2B3A binding site. Von Willebrand disease has a prevalence of 1%. However, only 1/10 of them are symptomatic. The female to male ratio is about 2:1. It's categorized into 3 types. Type 1 is partial qualitative deficiency, account for 70% of cases. And type 2 is a qualitative abnormality, about 25% of cases. Type 3 is complete deficiency, less than 5% of cases. So type 1, type 3 are quantitative abnormality. Type 2 is qualitative. So in type 2, you can see there are 2 subcategories. One is defective platelet adhesion. The other one is defective Fact8 binding. So in type 2A, there is selective deficiency of high molecular weight multimers. In type 2B, the deficiency exists in the platelet binding site. So the von Willebrand factor with type 2B have increased affinity for platelets, so they will bind platelets, activate it, and cause consumption of both. So you will see loss of high molecular weight multimers as well as thrombocytopenia in those patients. Type 2M, normal multimer pattern, however, there's decreased platelet or matrix binding capacity. For type 2N, Normandy, von Willebrand disease, the defect exists in the Fact8 binding site. So there is marked decrease of Fact8 level because the von Willebrand factor cannot bind to Fact8 to protect it from proteolysis in the circulation. However, the platelet adhesion part is still normal. And multimer pattern is also normal. So according to the NHLBI guideline as well as the ASH guideline, the initial screening test for von Willebrand disease would include an antigen level, activity, and Fact8 activity. Resuscitant has historically been the gold standard for measuring von Willebrand factor activity. However, it's a live assay that requires donor platelets and the patient plasma, and so there's relatively high inter and intra variability of this assay. So we have vigorously validated a latex-based immunoassay that has demonstrated very nice correlation with the resuscitant CoFact assay and superior sensitivity and specificity in differentiating between the type 1 and type 2M von Willebrand disease, and also better sensitivity and specificity in detecting the acquired von Willebrand syndrome. So in our lab, our default VWF activity assay is a latex-based immunoassay. However, with a abnormal antigen level or activity level, the resuscitant CoFact assay is reflexively added. Additional testing for von Willebrand disease workup include a multimer analysis and a RIPA and activity assay that measures the collagen binding activity. So this is a table that summarizes the findings in various types of VWD. Don't have time to go through all of them, and you can read them at your leisure. But I do want to point out that you can see the type 1, we're having the normal multimer pattern. In type 2A, we have loss of high molecular weight multimers. In type 2B, it's consumption, right? Have increased affinity, so consumption of high molecular weight multimers, and also decreased platelet count. Type 2M and 2N is normal pattern, and type 3 is absence of von Willebrand factor. Besides the congenital von Willebrand disease, we also have identified or recent years describe multiple causes for acquired von Willebrand syndrome, and autoantibodies, shear stress-induced VWF proteolysis, thrombocytosis-associated proteolysis, aberrant binding to tumor cells, decreased synthesis, etc., and drug-related. So that's it for the primary hemostasis part. And switching gears to the secondary hemostasis screening test, Dr. Nichols just mentioned, we have the APTT that measures the factors starting from factor 12, and the PT measuring the extrinsic pathway starting from factor 7. And we usually add in the thrombin time that helps to exclude or investigate the possibility of a heparin or direct thrombin inhibitor effect in the sample. So the thrombin time and rat place time, we would usually add in the rat place time if the thrombin time is abnormal. The two assays, they have the same substrate and final product. However, the enzyme being used is different. In the thrombin time, thrombin is added. In rat place time, rat place is added. This is a snake venom. The difference is that thrombin is sensitive to heparin and direct thrombin inhibitor inhibition. However, rat place is resistant to heparin or direct thrombin inhibitor effect. So therefore, with a prolonged thrombin time and a normal rat place time, that's indicating there's presence of heparin or direct thrombin inhibitor inside the sample. Whereas if both are prolonged, there are multiple causes that can be contributed to: hypofibrinogenemia, dysfibrinogenemia, interference from the elevated fibrin degradation product or paraprotein, the nonspecific interference of the assay, and other spurious anticoagulant artifacts such as an EDTA tube or an underfilled tube. So Dr. Nichols just mentioned the causes of the prolonged clotting time can be categorized into factor deficiency, inhibitors, dysfunctional factors, and pre-analytical artifacts. This is a summary table again for the prevalences of congenital coagulation factor deficiencies, and we can see the most common one is hemophilia A with a prevalence of 1 in 5,000, hemophilia B the second with a prevalence of 1 in 30,000. Hemophilia C is relatively uncommon. However, in the homogeneous population of Ashkenazi Jews, it can be up to 4%. Typical APTT and PT tests have different sensitivities for different factor deficiencies, and Dr. Nichols has mentioned. The level shown here is a ballpark estimation, and it's worth to mention that those sensitivities, they are actually determined by the specific combination of the reagent as well as the testing platform that is being used. And both PT and APTT are not sensitive for factor 13 deficiency, and factor 13 deficiency is analyzed by a specific assay. So in workup of a prolonged PT and APTT, the number one priority, if you have adequate information, is to rule out a pre-analytical artifact, such as if we know the hematocrit is higher than 55%, that can result in relative deficiency, actually lower number of plasma with relative excess of anticoagulant, which can cause falsely prolonged clotting time. So erythrocytosis, or if we know it's a round tube, or there's poor storage or transportation conditions. If we know they are present, then the sample should be rejected, and then the correct sample be collected for repeat testing. If that's normal, then we don't have to do anything further. If we had corrected the pre-analytical artifact and the clotting time is still abnormal, if you have access to clinical history, we should go in and take a look and see whether the patient is receiving any therapeutic anticoagulant, or is the patient have any systemic disorder, such as a liver disorder. Then it's a clinical judgment to decide whether the assay should be performed at this time or not, because if the patient is on anticoagulant, Dr. Nichols just mentioned, we do not want those kind of samples. So if the patient is on a factor Xa inhibitor or direct thrombin inhibitor, maybe you can consider redraw the sample after 5 half-lives. So if we have a clean sample that the APTT and PT are prolonged, the next step to perform is, of course, a mixing study. If it cracks, then it's a clot factor deficiency, and additional specific factor assays could be added to investigate for specific factor deficiencies. If it's inhibited, that's indicating there's an inhibitor present in the sample, and additional testing can be performed to determine the type of inhibitors, such as whether it's a therapeutic effect, or if this is a specific factor inhibitor, such as factor 8 inhibitor or factor 5 inhibitor, or it's a non-specific factor inhibitor, such as a lupus anticoagulant. So our special coagulation lab is a reference lab, so we do offer a bleeding diathesis panel that we would perform a battery of screening tests up front, and then reflexively adding the additional testing according to what we find from the screening assay in an algorithmic approach. So the assay that are performed up front include APTT, the ones in the blue box, APTT, PT, thrombin time, von Willebrand factor antigen activity, factor 8 activity, factor 9, only in male because of the prevalence, fibrinogen, fibrin D dimer, and factor 13 screen. So if the APTT is normal, then nothing else needs to be done in this arm. If it's prolonged, then we proceed with a mixing study, and if it's corrected sufficiently, then depending on whether we need further clarification, if yes, then we would add in the factor assays. For PT, the same. If it's normal, nothing needs to be done. If it's abnormal, then we would do the mixing study, and if additional clarification is needed, we would add in the extrinsic pathway factors for further evaluation. Thrombin time, if it's normal, nothing needs to be done. If it's abnormal, then we add in the Laplace time. This box is grayed out. Those are the additional lupus anticoagulant testing. Clinically, we know that lupus anticoagulant usually gives a thrombosis rather than bleeding diathesis, but it's an important differential to work up a prolonged and inhibited APTT as a reference lab, even though we ask people to fill out the clinical information sheet. Most of the time, we don't get it. So to close the loop, we felt it's prudent to include it in. But if you are offering the test in your own lab, it's your own clinical judgment. And then the same for Willebrand disease workup. If the antigen level is normal, then we look at activity antigen ratio. If it's normal, nothing needs to be done. If it's low, then we would add the multimers that has increased sensitivity or detecting the acquired von Willebrand syndrome. If the antigen level or the activity level is low, then we would add in the resuscitant activity. A low activity, we would also add in the multimers. Normal, there's nothing else to be done. Same for factor 8. If it's normal, then we stop. If it's abnormal, then we would look at the sample and see whether there's any suspicion for factor 8 inhibitor. If yes, then we would call the client and ask whether they want inhibitor screen done or not. If yes, then we would proceed, and with the positive screening, we would add in the Bethesda titer. So as you mentioned, we offer this as a limited bleeding panel because we do not include the platelet functional assays because those has to be done within 4 hours. So that's essentially what I have for the screening assays.